Test, test. Okay. Skin cancer. 509 to 512 or something. Skin cancer. Pathophysiology. Overexposure to sunlight is the major cause of skin cancer, although other factors are associated. Because sun damage is an age-related skin finding, screening for suspicious lesions is an important part of physical assessment of the older adult. The most common skin cancers are actinic or solar keratosis, squamous cell carcinoma, basal cell carcinoma, and melanoma. Table 27.6 describes common skin cancers. Etiology and genetic risk. Actinic keratosis are pre-malignant lesions of the cells of the epidermis. These lesions are common in people with chronically sun-damaged skin. Progression to squamous cell carcinoma may occur if lesions are untreated. Squamous cell carcinomas are cancers of the epidermis. They can invade locally and are potentially metastatic. Lesions on the ear, lip, and external genitalia are more likely to invade and spread than those found elsewhere on the body. Figure 2712. Chronic skin damage from repeated injury or irritation also predisposes to this malignancy. Basal cell carcinomas arise from the basal cell layer of the epidermis. Figure 2713. Early malignant lesions often go unnoticed, and although metastasis is rare, underlying tissue destruction can progress to include vital structures. Genetic predisposition and chronic irritation are risk factors. However, UV exposure is the most common cause. Melanomas are pigmented cancers arising in the melanin-producing epidermal cells. Figure 2714. Risk factors include genetic predisposition, excessive exposure to UV light, and the presence of one or more precursor lesions that resemble unusual moles. The skin cancer is highly metastatic, this skin cancer, melanomas, is highly metastatic, and a person's survival depends on early diagnosis and treatment. Lighter skin and less pigmentation are genetically inherited traits. Also, a genetic mutation that is inherited in an autosomal dominant pattern has been found for some cases of familial melanoma. The mutation occurs in a suppressor gene, resulting in loss of control of cell growth. Two such mutated genes are CDKN2A and CDK4. Incidence/prevalence. The incidence of skin cancer is highest among light-skinned races and people older than 60 years. The incidence is higher among those who work outdoors, live at higher altitudes or lower latitudes, or spend significant amount of time sunbathing. Occupational exposure to arsenic or other chemical carcinogens also increase risk. The incidence of melanoma has increased during the past 30 years, accounting for 2% of all cancers and 1% of all cancer deaths. Health promotion and maintenance. The single most effective prevention strategy for skin cancer is avoiding or reducing skin exposure to sunlight. However, even when people understand the cause of skin cancer and the seriousness of the disease, preventative behaviors are not always practiced. Common prevention practices include direct sunlight, using sunscreen, and wearing protective clothing, including hats, whenever a person is in the sun to prevent severe sunburn. Teach all people to avoid tanning beds and salons. Those are pretty bad, I guess. Chart 2711 lists methods of prevention that patients can use to reduce the risk for skin cancer. Table 27.6 Common skin cancers. Clinical manifestations: actinic keratosis, or pre-malignant. Small, 1 to 10 millimeter macule or papule with dry, rough, adherent yellow or brown scale. Distribution would be cheeks, temples, forehead, ears, neck, backs of hands, and forearms. Course: may disappear spontaneously or reappear after treatment. Clinical manifestations: base may be erythematosus, also associated with yellow, wrinkled, weather-beaten skin. Course would be slow progression to squamous cell carcinoma is possible. Also, thick, indurated keratosis, more likely to be malignant. That was actinic keratosis, or pre-malignant. And then squamous cell carcinoma, firm nodular lesion topped with a crust or with a central area of ulceration. Distribution would be sun-exposed areas, especially head, neck, and lower lip. Rapid invasion. Of course, it would be rapid invasion with metastasis via the lymphatics, occur in 10% of the cases. Sites of chronic irritation or injury, e.g. scars, irradiated skin burns, or leg ulcers, also where it happens. Indurated margins: fixation to underlying tissue with deep invasion. This has to do with larger tumors or more prone to metastasis. To basal cell carcinoma. This would be a pearly papule with a central crater and rolled wavy borders. A telangiectasias and pigment flecks visible on closed inspection. Sun-exposed areas, especially head, neck, and central portion of face, is where it shows up. And of course, would be metastasis is rare, basal cell carcinoma, and may cause local tissue destruction, 50% recurrence rate related to inadequate treatment. And then on to melanoma. Irregular shaped pigmented papule or plaque, variegated colors with red, white, and blue tones, can occur anywhere on the body, especially where nevi or moles or birthmarks are evident. commonly found on upper back and lower legs, and soles of feet and palms in dark-skinned people. Horizontal growth phase followed by vertical growth phase. Rapid invasion and metastasis with high morbidity and mortality. Don't get melanoma. Secondary prevention, early detection, is critical to survival with melanoma. Teach all people to be aware of their skin markings. Keep a total body spot and lesion map. Keeping a total body spot and lesion map can provide baseline information about the suspicious lesions and help identify changes in a lesion or lesions earlier. Once a map is made, the person should systematically inspect his or her body monthly for new lesions and for changes in any existing lesions by performing thorough skin self-examination, or TSSE, thorough skin self-examination, blah blah blah. Often a partner is needed to help evaluate skin spots or lesions on the back. Some people find taking pictures of their skin on a regular basis makes identifying changes easier. Teach everyone to evaluate all skin lesions using the ABCD guide for melanoma, see chapter 26, and to consult his or her healthcare provider to examine any lesions having unusual characteristics. When lesions such as moles are present, they should be monitored yearly by a dermatologist or healthcare professional. Evidence-based practice. Spot check with partners. Thorough skin self-examination, TSSE, is instrumental in detecting the presence of melanoma and other skin cancers early when cure is more likely. Patients who have been diagnosed with melanoma remain at increased risk for recurrent skin cancer or development of new melanoma. Therefore, continuing vigilance with TSSE on a monthly basis is needed even after treatment of an existing melanoma is completed. The purpose of this study was to determine to what extent patients previously diagnosed with treatment for melanoma participated in this important secondary prevention practice. 70 subjects with melanoma being followed at a large National Cancer Institute designated comprehensive cancer center were enrolled in the study and returned all survey materials. Subjects were asked how frequently they examined the skin on all 7 body areas included as criteria for TSSE: front of body, from waist up, front of thighs and legs, bottom of feet, calves of legs, back of thighs, buttocks, and lower back and upper back. The whole body. Although 59% responded that they performed TSSE, only 23% of the body area criteria for thorough examination. Those subjects diagnosed with higher stages of disease were more likely to perform TSSE. The main factor in correct performance of TSSE was the inclusion of a partner in the actual examination. The exact role of the partner was not explored. It could be that the partner helped remind the patient to perform the examination, as well as served as an examiner and recorder. Level of evidence is 4. The study was well-designed cohort study. Commentary. Implications for practice and research. The practice of monthly TSSE has been demonstrated to significantly reduce mortality from melanoma by detecting it at an earlier stage. Patients who have already had melanoma remain at far greater risk for development of new lesions. The two most important implications for nursing are to ensure that patients with melanoma understand their continuing risk and to help them learn to incorporate correct TSSE practice into their lives. The fact that partner participation increases adherence to regular performance of TSSE could be a focus of teaching. Teach the patient and the partner at the same time. Demonstrate how to actually do the examination and exactly what to report. Patient and Family Education Guide. Prevention of skin cancer. Avoid sun exposure between 11 a.m. and 3 p.m. Use sunscreens with the appropriate skin protection factor for your skin type. Wear a hat, opaque clothing, and sunglasses when you are out in the sun. Keep a body map of your skin, spots, scars, and lesions to detect when changes have occurred. Examine your body monthly for possibly cancerous or precancerous lesions. Seek medical advice if you note any of these. A change in the color of a lesion, especially if it darkens or shows evidence of spreading. A change in the size of a lesion, especially rapid growth. A change in the shape of a lesion, such as a shape border becoming irregular or a flat lesion becoming raised. Redness or swelling of the skin around a lesion. A change in sensation, especially itching or increased tenderness of a lesion. A change in the character of a lesion, such as oozing, crusting, bleeding, or scaling. Monthly TSSE is critically important for patients who have already had a melanoma lesion. A recent study found that only about 23% of those who had been treated for melanoma regularly practiced TSSE correctly. The major positive influence for TSSE practice was working with a partner in this examination. See evidence-based. Patient-centered collaborative care assessment. In addition to age and race, ask the patient about any family history or skin cancer, any past surgery for removal of skin growths, recent changes in the size, color, or sensation of any mole, birthmark, wart, or scar are also significant. Ask about which geographic region he or she has lived in and where, with the hiccups, he or she currently resides. Obtain information about occupational and recreational activities in relation to sun exposure, as well as any occupational history or exposure to chemical carcinogens, e.g. arsenic, coal, tar, pitch, radioactive waste, radium. Ask whether any skin lesions are repeatedly irritated by the rubbing of clothing. Skin that has been injured previously is at greater risk for cancer development, an effect known as Cobner's phenomenon. Ask the patient if he or she has ever experienced a severe skin injury that resulted in a scar. Examine all scarred skin areas for the presence of potentially cancerous lesions. The skin cancers vary in their appearance and distribution. Although most skin cancers appear in sun-exposed areas of the body, inspect the entire skin surface. Systematically examine the skin for any unusual lesions, particularly moles, warts, birthmarks, and scars. Also examine hair-bearing areas of the body, such as the scalp, and genitalia. Palpate lesions to determine surface texture. Document the location, size, color, and surface features of all lesions and any subjective reports of tenderness or itching. Use the ABCD method of evaluating all lesions for possible melanoma. See Chapter 26 for the ABCD method. Table 27.6 lists facts about common skin cancers. Punch, shave, or excisional biopsy of suspicious lesions is necessary to determine whether a skin lesion is benign or malignant. Interventions. Surgical and non-surgical interventions are combined for the effective management of skin cancer. Treatment is determined by the size and severity of the malignancy, the location of the lesion, and the age and general health of the patient. Surgical management. Surgical intervention is the most common means of managing any type of skin cancer. It can range from local removal of small lesions with minimal discomfort and positive cosmetic results to massive excision of large areas of the skin and underlying tissue for treatment of melanoma. Cryosurgery. Cryosurgery involves the local application of liquid nitrogen, negative 200 degrees Celsius, to isolated lesions, causing cell death and tissue destruction. Local anesthesia is seldom needed because most patients have only minor discomfort during the procedure. Prepare patients for swelling and increased tenderness of the treated area when the skin thaws. Tissue freezing is followed in 1 to 2 days by hemorrhagic blister formation. Instruct patients to clean the sites with hydrogen peroxide to prevent infection. A topical antibiotic may also be prescribed. Curettage. Curettage is Curettage, and electrodesiccation may be used for small lesions that are not melanoma. This method can destroy the cancerous cells while minimizing damage to the surrounding uninvolved tissue. After a local anesthetic is given, the surgeon uses a dermal curettage. That's it. A dermal curette to scrape away the cancerous tissue. After curettage is complete, the surgeon places an electric probe on the wound, and remnants of the tumor are destroyed by thermal energy. Wounds created by this treatment heal by second intention, and scarring is usually minimal. Instruct patients in caring for the wound, including cleaning the wound, using prescribed antibacterial drugs, and applying dressings. Excision is used for biopsy of small lesions. When the diagnosis is melanoma, a sentinel node may be biopsied to determine whether tumor spread has started. See Chapter 23. If the size and location of the lesion permit surgical excision with primary closure is the preferred method. If the size and location of the lesion permit surgical excision with primary closure is the preferred method. If the tumor has already been removed several times, or if radiation therapy has damaged the surrounding skin, healing by second intention is indicated. This procedure allows the wound to be monitored for cancer recurrence. Skin grafts and flaps are used to repair defects if tissue destruction is deep. Mohs surgery, M-O-H-S apostrophe surgery, a specialized form of excision, is used to treat basal and squamous cell carcinomas. The cancerous tissue is sectioned horizontally in layers, and each layer is examined histologically to determine the presence of residual tumor cells. Although the procedure is long and tedious, cure rates are high and there is less removal of healthy tissue compared with other surgical methods. Wide excision. Wide excision for deeper melanoma or other skin cancers that are large or invasive often involves removing full thickness skin in the area of the lesion. Depending on tumor depth, subcutaneous tissues and lymph nodes may also be removed. If the remaining skin is easily moved without creating extensive tension, the wound may be just sutured closed. If the remaining skin is tight or the wound is large, skin grafts may be needed to close the surgical wound. See earlier discussion on page 495-496. Non-surgical management. Drug therapy may involve topical or systemic chemotherapy, biotherapy, or targeted therapy. Topical chemotherapy with 5-fluorouracil cream is used for treatment of multiple actinic keratosis or for widespread superficial basal cell carcinoma that would require several surgical procedures to eradicate. Therapy is continued for several weeks and the treated areas become increasingly tender and inflamed as the lesions crust, ooze, or erode. Prepare the patient for an unsightly appearance during therapy and reassure him or her that the cosmetic result will be positive. After treatment is discontinued, cool compress and topical corticosteroid preparations help decrease inflammation and promote comfort. Systemic chemotherapy agents are used in the treatment of skin cancer, except when the prognosis is poor, as in advanced melanoma. Biotherapy with interferon is now an accepted treatment after surgery for melanomas that are at stage 3 or higher. The patient is first started on high dose 20 million units per M2 meters to the second power, I'm not sure, M2 interferon IV infusions daily for 5 days per week for 4 weeks after the surgical wound is well healed. Maintenance doses of 10 million units are continued 3 times per week for 1 year. The maintenance doses are given subcutaneously, and the patient must learn to self-inject the drug. Experimental drugs that target lymphocyte control of tumor cell growth are being tried for treatment of metastatic melanoma. One promising type of agent currently in clinical trials is a drug that targets CTLA4 receptor and blocks it, resulting in significant tumor cell regression. Because the receptor is present on certain lymphocytes, the side effects of the drug include inflammation in a wide variety of tissues. Radiation therapy for skin cancers is limited to older patients with large, deeply invasive basal cell tumors and to those who are poor risks for surgery. Malignant melanoma is resistant to radiation therapy. However, radiation therapy may be helpful for patients with metastatic disease when used in combination with systemic corticosteroids. NCLEX examination challenge. Which statement made by a client with a skin lesion indicates the need for further teaching? A. My wife helps me keep track of all my skin spots and lesions every month. B. Usually I cover the spot with a small bandage so my belt doesn't rub it. C. At least I know this spot is not melanoma because it is red, not black. D. I should use sunscreen and clothing to protect my skin and sunburn. I'm going to say that's C. Okay, on to oral tumors, 1234 to 1239 in Iggy. Oral tumors. Oral cavity tumors can be benign, precancerous, or cancerous. Whether benign or malignant, tumors of the mouth affect many daily functions, including swallowing, chewing, and speaking. Pain accompanying the tumor can also limit daily activities and self-care. Oral tumors affect body image, especially if treatment involves removal of the tongue or part of the mandible or jaw, or requires a tracheostomy. Premalignant lesions. Leukoplakia. Leukoplakia presents as slowly developing changes in the oral mucous membranes, causing thickened, white, firmly attached patches. These patches appear slightly raised and sharply rounded. Most of these lesions are benign. However, a small percentage of them become cancerous. Although leukoplakia can be found anywhere on the oral mucosa, lesions on the lips or tongue are more likely to progress to cancer. Leukoplakia results from mechanical factors that cause long-term oral mucous membrane irritation, such as poorly fitting dentures, chronic cheek nibbling, or broken or poorly repaired teeth. In addition, oral hairy leukoplakia can be found in patients with HIV infection. Tobacco products, especially chewing tobacco and pipes, have also been implicated in the development of leukoplakia, sometimes referred to as smoker's patch. Oral leukoplakia can be confused with oral candidal infection. However, unlike candidal infection, leukoplakia cannot be removed by scraping. Leukoplakia is the most common oral lesion among adults. Oral hairy leukoplakia is an early manifestation of HIV disease and is highly correlated with progression from HIV infection to acquired immune deficiency syndrome AIDS. Leukoplakia not associated with HIV disease is more often seen in people older than 40 years. Men have twice the incidence of leukoplakia than women have. But this ratio is changing because increasing numbers of women are smoking. Erythroplakia. Erythroplakia presents as a red, velvety, mucosal lesion on the surface of the oral mucosa. There are more malignant changes in erythroplakia than in leukoplakia. As such, these lesions should be regarded with suspicion and analyzed by biopsy. Erythroplakia is most commonly found on the floor of the mouth, tongue, palate, and mandibular mucosa. It can be difficult to distinguish from inflammatory or immune reactions. Oral cancer. In the past decade, dentists and physicians have begun systematically screening their patients for oral cancer. Oral assessment has become a part of the routine dental examination. People should visit a dentist at least once or twice a year for professional dental hygiene and oral cancer screening, which includes inspecting and palpating the mouth for lesions. Prevention strategies for oral cancer include minimizing sun and tanning bed exposure, tobacco cessation, and decreasing alcohol intake. Most dentists now use digital technology instead of x-rays when performing the annual or biannual dental examination. Excessive prolonged radiation from x-rays has been associated with head and neck cancer. Teach patients to follow the guidelines in Chart 56.1 to maintain oral health. A new mouth rinse has been developed that could diagnose many cases of oral cancer in its early stages. This rinse works by identifying CD44, a protein tumor biomarker on the surface of healthy tissue that increases with oral cancer. This simple, non-invasive test could save thousands of patients whose lives are now shortened because they were diagnosed in the advanced stage of the disease. Pathophysiology. Squamous cell carcinoma. More than 90% of oral cancers are squamous cell carcinomas that begin in the surface of the epithelium. Over a period of many years, premalignant or dysplastic changes begin. Cells begin to vary in size and shape. Alterations in thickness of the lining of the epithelium develop, resulting in atrophy. These tumors usually grow slowly, and the lesions may be large before the onset of symptoms unless ulceration is present. Mucosal erythroplasia is the earliest sign of oral carcinoma. Oral lesions that appear as red, raised, eroded areas are suspicious for cancer. A lesion that does not heal within 2 weeks or a lump or thickening in the cheek is a symptom that warrants further assessment. Squamous cell cancer can be found on the lips, tongue, buccal mucosa, and oropharynx. The major risk factors in its development are increasing age, tobacco use, and alcohol use. Most oral cancers occur in people older than 40 years. Tobacco use in any form, e.g. smoking or chewing tobacco, can increase the risk for cancer. A person who frequently consumes alcohol and uses tobacco in any form is at the highest risk. Genetic changes in patients with oral cancer have been found, especially the mutation of the TP53 gene. An increased rate of oral cancer is found in people with occupations such as textile workers, plumbers, and coal and metal workers. Additional factors such as sun exposure, poor nutritional habits, poor oral hygiene, and infection with the human papillomavirus, HPV-16, may also contribute to oral cancer. People with periodontal or gum disease, in which mandibular or jawbone loss has occurred, are especially at risk for cancer of the mouth. Mouth cancers account for about 3% of all cancers in men and 2% of all cancers in women in the United States. Over 34,000 new cases are diagnosed each year, with almost 8,000 deaths. Most cancers occur in middle-aged and older people, although in recent years, younger adults have been affected, probably as a result of sun exposure. Basal cell carcinoma. Basal cell carcinoma of the mouth occurs primarily on the lips. The lesion is asymptomatic and resembles a raised scab. With time, it evolves into a characteristic ulcer with a raised pearly border. Basal cell carcinomas do not metastasize or spread, but can aggressively involve the skin of the face. The major risk factor for this type of cancer is excessive sunlight exposure. Basal cell carcinoma occurs as a result of the failure of basal cells to mature into keratinocytes. It is the second most common type of oral cancer, but is much less common than squamous cell carcinoma. Kaposi's sarcoma. Kaposi's sarcoma is a malignant lesion in blood vessels. It is usually painless and appears as a raised purple nodule or plaque. In the mouth, the hard palate is the most common site of Kaposi's sarcoma, but it can be found also on the gums, tongue, or tonsils. It is most often associated with AIDS. See Chapter 21 for a complete discussion of Kaposi's sarcoma. Patient-centered collaborative care. Assessment. Begin by assessing the patient's routine oral hygiene regimen and use the dentures or use of dentures or oral appliances, which might add to discomfort or mechanically irritate the mucosa. Ask about oral bleeding, which might indicate an ulcerative lesion. Determine the patient's past and current appetite and nutritional state, including difficulty with chewing or swallowing. A continuing trend of weight loss may be related to metastasis, heavy alcohol intake, difficulty in eating or chewing, or an underlying health problem. An examination of the oral cavity requires adequate lighting. Thoroughly inspect the oral cavity for any lesions, evidence of pain, or restriction of movement. Using a tongue blade, examine all areas of the mouth. Carefully note any change in speech caused by tongue movement. Notice any change in voice or swallowing and assess for thick or absent saliva. After inspection, the advanced practice nurse or specialty nurse uses bimanual palpation of any visible nodules to determine size and fixation. The cervical lymph nodes should also be palpated. The functioning and appearance of the mouth are strongly linked with body image and quality of life. Therefore, it is important to assess the impact of oral lesions on the patient's self-concept. In addition, assess for any educational or cultural needs that might affect health teaching or treatment. Evaluate the patient's support system and past coping mechanisms. 56.2 figure the lymph nodes of the cervical region. There's the post-auricular, auricular, and occipital behind the ear, back of the neck. Superficial cervical, a little bit farther down below the ear. Post-cervical, about the middle of the back of the neck. Submaxillary, and is the side of the jaw, under the big jaw there. Submentals by the chin. And tonsillar is back where the tonsils are. Deep cervical chain, side of the neck, and supraclavicular is at the base of the clavicle on the side of the neck. Oral CDX brushing of a lesion is helpful in determining whether it is precancerous. This procedure is usually performed by a dentist during a routine dental examination. However, biopsy is the definitive method for diagnosis of oral cancer. The physician obtains a needle biopsy specimen of the abnormal tissue to assess for malignant or pre-malignant changes. Incisional biopsies may also be performed. An intraoral biopsy can be done under local anesthesia in very small lesions. An excisional biopsy can permit complete tumor removal. Magnetic resonance imaging, MRI, is useful in detecting perineural involvement and in evaluating thickness in cancers of the tongue. Both CT and MRI can be used to determine spread to the liver or lungs if further staging of the disease is warranted. An aqueous solution of toluidine blue 1% can be applied to oral lesions to determine if they are malignant.
This preparation stains malignant lesions, leaving normal tissue unaffected. However, a lesion that is the result of an inflammatory process may also absorb the stain, leading to a false positive result. Although a biopsy is still needed to confirm a cancer diagnosis, toluidine blue may be useful for screening high-risk patients. Common nursing diagnoses and collaborative problems. Based on the nursing assessment, nursing diagnoses and collaborative problems that may apply to patients with oral cancer depending on the extent of the disease include risk for ineffective airway clearance related to obstructed airway by the tumor, edema, or secretions, impaired oral mucous membrane related to pathologic condition from the tumor, impaired verbal communication related to physical barrier or anatomic defect, disturbed body image related to surgery, acute pain related to physical injury, risk of infection related to invasive procedures, impaired swallowing related to oral cavity or oropharyngeal abnormalities, imbalanced nutrition less than body requirements related to inability to ingest food, potential for metastasis. Interventions. Both the presence of tumors of the oral cavity and the effects of the treatment threaten the integrity of the oral mucosa and the patient's airway. Oral cavity lesions can be treated by surgical excision, by non-surgical treatments such as radiation or chemotherapy, or by a combination of treatments, referred to as multimodal therapy. Multimodal therapy is the most common treatment option. Nursing interventions focus primarily on restoring and maintaining oral health. If the patient has extensive tumor involvement and copious, tenacious, thick, and stringy secretions, maintaining an open airway is the primary focus. Non-surgical management. If needed, implement interventions to manage the patient's airway. By increasing air exchange, removing secretions, and preventing aspiration. Assess for dyspnea resulting from the tumor obstruction or from excessive secretions. Assess the quality, rate, and depth of respirations. Auscultate the lungs for adventitious sounds such as wheezes caused by aspiration. Listen for stridor caused by partial airway obstruction. Promote deep breathing to help produce an effective cough to mobilize the patient's secretions as described in chart 56.3. To increase air exchange, place the patient in a semi-Fowler's or high Fowler's position. Encourage fluids to help liquefy secretions. Chest physiotherapy also increases air exchange as well as promotes effective coughing. If available, collaborate with the respiratory therapist about performing this procedure. If needed, use oral suction equipment with a dental tip or a tonsil tip, a Yankauer catheter, to remove secretions that obstruct the airway. Teach the patient and family to use the catheters as needed. If edema occurs with oral cavity lesions, the patient may receive steroids to reduce inflammation. Antibiotics may be prescribed if infection is present because it can increase inflammation and edema. If edema occurs with oral cavity lesions, the patient may receive steroids to reduce inflammation. Antibiotics may be prescribed if infection is present because it can increase inflammation and edema. Okay. Cool mist supplied by a face tent may assist with oxygen transport and control of edema. Okay. Oh, I don't know. Aspiration precautions prevent or reduce the risk factors for aspiration. Assess the patient's level of consciousness, gag reflex, and ability to swallow. To prevent aspiration, place the patient sitting upright at 90 degrees, high Fowler's position. As a precaution, keep suction equipment nearby. For patients at high risk, assess the gag reflex before giving any fluids. Remind UAP and visitors unlicensed assisted personnel and visitors to feed patient at risk for aspiration in small amounts. Thickened liquids can be used as an aid to prevent aspiration. It is important to work with the patient to establish an oral hygiene routine. Ideally, oral hygiene is performed every 2 hours for ulcerated lesions, infection, or in the immediate postoperative period. Modifications might be needed because of oral discomfort, bleeding, or edema. Oral care with a soft bristled toothbrush is preferred. If the platelet count falls below 40,000, switch the patient to an ultra-soft chemo brush. The use of tooth-ettes or a disposable foam brush is discouraged because these products may not adequately control bacteremia promoting plaque. Lubricant can be applied to moisten the lips and oral mucosa as needed. Chart 56.3, Intervention Activities. The patient with oral cancer. Airway management. Facilitation of patency of air passages. Position patient to maximize ventilation potential. Remove secretions by encouraging coughing or by suctioning. Instruct how to cough effectively. Auscultate breath sounds, noting areas of decreased or absent ventilation and presence of adventitious sounds. Administer humidified air or oxygen as appropriate. Position to alleviate dyspnea. Monitor respiratory and oxygenation status as appropriate. Cough enhancement. Promotion of deep inhalation by the patient with subsequent generation of high intrathoracic pressures and compression of underlying lung parenchyma for the forceful expulsion of air. Okay. Assist patient to a sitting position with the head slightly flexed, shoulders relaxed, and knees flexed. Encourage patient to take several deep breaths. Encourage patient to take a deep breath, hold it for 2 seconds, and cough 2 or 3 times in succession. Instruct patient to inhale deeply, bend forward slightly, and perform 3 or 4 huffs against an open glottis. Instruct patient to inhale deeply several times, to exhale slowly, and to cough at the end of exhalation. Instruct patient to follow coughing with several maximal inhalation breaths. Promote systematic fluid hydration as appropriate. Aspiration precautions. Prevention or minimization of risk factors in the patient at risk for aspiration. Monitor level of consciousness, cough reflex, gag reflex, and swallowing ability. Monitor pulmonary status. Maintain an airway. Position upright 90 degrees or as far as possible. Feed in small amounts. Avoid liquids or use thickening agents. Offer foods or liquids that can be formed into a bolus before swallowing. Cut food into small pieces. Request medication in elixir form. Break or crush pills, if appropriate, before administration. Keep head of bed elevated 30 to 45 minutes after eating. Now back to the text. Teach patients and their families to avoid using commercial mouthwashes and lemon glycerin swabs. Commercial mouthwashes contain alcohol, and lemon glycerin swabs are acidic. These substances can cause a burning sensation and contribute to dry oral mucous membranes. Encourage frequent rinsing of the mouth with sodium bicarbonate solution or warm saline. See also chart 56.2. Follow hospital or healthcare provider protocol if available. Radiation therapy has been used alone, as well as with surgery and chemotherapy for oral cancer. The purpose of radiation therapy is tumor reduction while preserving the patient's function and appearance. There are several ways to apply radiotherapy. In collaboration with the patient, the oncologist or other qualified physician chooses the best mode on the basis of the tumor site and staging. Radiation therapy for oral cancers can be given by external beam or interstitial implantation. External beam radiation passes through the skin or mucous membrane to the tumor site. Typically, treatments are given as 5 daily treatments per week over a 6 to 9 week period. Special precautions are taken to minimize the dose of radiation to the brain or spinal cord. Another option is the implantation of radioactive substances, interstitial radiation therapy, or brachytherapy, either to boost the dosage or to deliver a radiation dose close to the tumor bed. This form of implant therapy can be curative in early stage lesions in the floor of the mouth or anterior tongue. It may also add a boost of radiation to a tumor that received external beam radiation. Interstitial radiation is used for smaller lesions that do not infiltrate surrounding tissues. Radioactive materials can be seeds, which are permanently implanted into the tissue, usually for tumors that cannot be completely excised or in neck nodes, needles or wires, which are removed at the end of therapy, radiation catheters or holders, which are loaded with radioactive materials, a mold of radioactive material placed directly over the lesion for a specific time. With the exception of radioactive seeds, which have a low level of emission, patients receiving interstitial radiation are usually hospitalized for the duration of treatment. Place patients on radiation transmission precautions while the materials are active or in place. A tracheostomy may be required with interstitial implants because of edema and increased oral secretions. See Chapter 24 for general nursing care of patients undergoing radiation therapy. The patient may receive one or more types of drug therapy. The advantages of drug therapy instead of or as an adjunct to surgery or radiation for cancer of the oral cavity continue to be evaluated. Teach the patient undergoing chemotherapy and family about the side effects of the drugs, which vary with each drug. Give antiemetics as prescribed and provide other comfort measures as needed. See Chapter 24 for general care of patients receiving chemotherapy. One of the most recent advances in the use of drugs for oral cancer is targeted therapy. Hormone-like substances known as growth factors, GFs, occur in the body's cells. Oral tumor cells, along with other types of cancers, grow quickly because they have more GF receptors than normal healthy tissue. One of these GFs is called epidermal growth factor, EGF, which has been associated with oral cancers. New drugs that can target and block EGF receptors, EGF-R, are being tested, and more than a dozen have been approved, including cetuximab, or Erbitux, and erlotinib, or Tarceva. Chapter 24 describes targeted molecular therapy. Surgical management. The physician can often remove small, non-invasive lesions of the oral cavity in an ambulatory setting with local anesthesia. The surgical defect is usually small enough to be closed by sutures. These smaller lesions may also be responsive to carbon dioxide laser therapy or cryotherapy, extreme cold application, as well as photodynamic therapy. These procedures can be performed as an ambulatory care procedure in a surgical center, but may require general anesthesia. Small oral cancers are equally responsive to radiation or photodynamic therapy and to surgery. More invasive lesions, stage 3 and 4, require more extensive surgical excision and result in a greater loss of function and disfigurement. Not all lesions can be excised by the peroral approach or through the mouth. The goal of surgical resection is removal of the tumor with a surgical margin that is free of cancer cells. Preoperative care. Before excision of a lesion in the oral cavity, assess and document the patient's level of understanding of the disease process, the rationale for the surgery, and the planned intervention. Problems associated with cancer therapy can be reduced or optimally managed with patient preparation and instruction. Reinforce information as needed. Include family members or other caregivers in the health teaching unless culturally inappropriate. For small local excisions, postoperative restrictions include a liquid diet for a day and then advancing as tolerated. There are no activity limitations, and postoperative analgesics are prescribed. Instruction for the patient undergoing large surgical resections may include, but are not limited to, these expectations after surgery. Placement of a temporary tracheostomy, oxygen therapy and suctioning, temporary loss of speech because of the tracheostomy, frequent monitoring of postoperative vital signs, NPO status until intraoral suture lines are healed, need to have IV lines in place for drug delivery and hydration, postoperative drug therapy and activity out of bed on the first postoperative day, possibility of surgical drains. Because communication is interrupted, assess the patient's ability to read and write. In coordination with the patient, select the method of communication to use after surgery with staff and family members, e.g., magic slate, computer, picture board, or pad and pencil. Urge the patient to practice the chosen method before surgery to reduce frustration after surgery. Operative procedures. 3 factors influence the extent of surgery performed for oral cancers: the size and location of the tumor, tumor invasion into the bone, and whether there has been metastasis or cancer spread to neck lymph nodes. Small, non-invasive tumors can be excised periorally or inside the mouth. Otherwise, an external approach may be used. The most extensive oral operations are composite resections, which combine partial or total glossectomy, or tongue removal, and partial mandibulectomy, or jaw removal. In the commando, or co-mandible procedure, the surgeon removes a segment of the mandible with the oral lesion and performs a radical neck dissection. See Chapter 31. Metastasis to cervical lymph nodes usually indicates a poor prognosis for patients with cancer of the oral cavity. In those with cervical node metastasis, a neck dissection may also be performed. A radical neck dissection usually involves the removal of all cervical lymph nodes on the affected side, along with cranial nerve 11, the internal jugular vein, and the sternocleidomastoid or front neck muscle. Modified and selective neck dissections may be done in patients with minimal lymph node involvement. Post-op care. The patient may have a temporary or permanent tracheostomy requiring intensive nursing care to promote airway clearance. In addition, care must be taken to protect the surgical incision site from mechanical damage and infections. See Chapter 31. Nursing interventions to relieve pain or discomfort and promote nutrition are also important. Older adults are a special risk for surgery and need to be monitored very carefully. After extensive excision or resection, the most important nursing intervention is maintaining the patient's airway. The patient may not recall on awakening from anesthesia what a tracheostomy tube is, that a tracheostomy tube is in place, and may initially panic because of the inability to speak. Remind the patient why he or she cannot speak and provide reassurance that the vocal cords are intact, unless a total laryngectomy has been performed, in which case the loss of voice is permanent. Ensure that the predetermined method of communication is available for the patient, family members, and staff. When the patient has an adequate airway and can effectively clear secretions by coughing, the tracheostomy tube may be removed. When the tube is removed, an airtight dressing is placed over the site and the tracheostomy incision heals without the need for sutures. Patients who have undergone extensive resection may have slurred speech or difficulty in speaking as a result of nerve damage or tongue removal. Yeah, that would make it difficult. Collaborate with the speech-language pathologist if speech is altered. Protect the incision site to avoid infection. It is important to provide gentle mouth care for cleaning away thick secretions and stimulating the flow of saliva. The delivery of oral care depends on the nature and extent of the surgical procedure. Oral care should be provided at least every 4 hours in the early postoperative phase. The presence of unusual odors from the mouth can indicate infection. In the early postoperative phase, care must be taken to avoid disruption of the suture line during oral hygiene. Chart 56.4, focused assessment, the postoperative older adult with oral cancer. Older adult with oral cancer. Okay. Assess the mouth and surrounding tissues for candidiasis, mucositis, and pain. Assess for loss of appetite and taste. Monitor the patient's weight, monitor nutritional and fluid intake, assess for difficulty in eating or speech, assess pain status and measures used to control pain, monitor the patient's response to medications, identify psychosocial problems such as depression, anxiety, and fear. Elevate the head of the bed to at least 30 degrees to assist in decreasing edema by gravity. If skin grafting was done, inspect the donor site, generally on the anterior thigh, every 8 hours for bleeding or signs of infection. See Chapter 31 for specific nursing care of the patient with a radical neck dissection. To provide optimal pain relief in the postoperative period, rely on subjective and objective data to assess the need for analgesics and the effectiveness of the drugs given. The outcome of drug therapy during this period is relief of pain while allowing the patient to function at an optimal level. Those who have undergone surgery for oral cancer describe their pain as throbbing or pounding. IV morphine is usually the initial pain medication given. Tylox or Percodan plus acetaminophen may be used for systematic relief of moderate pain. Patients who have undergone extensive resections of the oral cavity remain on NPO status for several days. This time allows healing in the oral cavity before food contacts the incision. Nasogastric feeding or total parenteral nutrition may be needed until oral nutrition can begin. When oral fluid intake is started, assess for and document difficulty in swallowing, aspiration, or leakage of saliva or fluids from the suture line. Nursing care should also include monitoring weight and hydration. Nutritional supplementation may be used to improve the patient's quality of life. Patients who have weight loss or who are having difficulty maintaining hydration may be candidates for surgical placement of a gastrostomy tube. Gastrostomy tube? Yeah, it works. Coordinate dietary care with the nutritionist. Encourage the patient to perform swallowing exercises, collaborate with the speech-language pathologist to assist with swallowing techniques. Thickened fluids may be needed to prevent aspiration. A swallowing impairment may be temporary or permanent. Community-based care. Continuing care for the patient with an oral tumor depends on the severity of the tumor, its treatment, and available support systems. Most patients are maintained at home during follow-up care. Ongoing nutritional management remains a vital part of the treatment plan. In addition, the patient and family may benefit from a community-based support group for cancer victims. Home care management if radiation therapy If radiation therapy is part of the patient's treatment plan, home care considerations include health teaching and management strategies. Complications due to radiation to the head or neck can be acute or delayed. Acute effects include treatment-related mucositis, stomatitis, and alterations in taste. Long-term effects such as xerostomia or excessive mouth dryness and dental decay require ongoing oral care, the use of saliva substitutes, and follow-up dental visits. Although ongoing dental care is important, the possible adverse effects that radiation has on bone make elective oral surgical procedures, such as tooth extraction, impossible in the area of the radiation. Fatigue is a common side effect of radiation and chemotherapy. The patient whose tracheostomy tube has been removed is often taking a soft diet by mouth before discharge. Occasionally, however, patients are discharged from the hospital while still requiring tracheostomy suction, oral suction, and nasogastric feedings. Suction equipment, nutritional supplies, and nursing care can be provided by home care companies. See Chapter 63 for home care preparation for the patient receiving home parenteral nutrition, and Chapter 31 for home care preparation for the patient with a tracheostomy. Health teaching. Teach the patient and family about drug therapy, nutritional therapies, any treatments, e.g. tracheostomy care, suture line care, dressing changes, and early symptoms of infection before hospital discharge. Alterations in taste and dysphagia make maintaining adequate nutrition a challenge for the oral cancer patient. Alterations in taste occur when the taste buds are included in the radiation treatment field. Taste sensation may begin to return several weeks after the completion of treatment. Sometimes the loss of taste is permanent. Changes in taste include dislike of meat, such as beef or pork, and metallic tastes in the mouth. Teach patient to add seasonings to food, to use gravies or sauces to make foods more palatable, and use high-protein foods such as cheeses, milks, eggs, puddings, and legumes in place of meat. Instruct patients with dysphagia in swallowing exercises. Recommend thickened liquids because thin liquids, such as water, are difficult to control during swallowing. Collaborate with the nutritionist to teach the family how to assess the nutritional intake of the patient who is just beginning to eat. Liquid dietary supplements are usually recommended at this time. If bleeding or stomatitis is present, a diet of soft foods is recommended to prevent further injury to the mucous membranes. Teach the patient or family members to inspect the oral cavity daily for areas of redness, indicating the onset of stomatitis. Meticulous oral hygiene should be continued at home, especially with adjuvant chemotherapy or radiation. Reinforce the oral hygiene routine, emphasizing the need for frequent mouth rinsing to reduce the number of microorganisms and to maintain adequate hydration. The patient should use a chemo brush. Rinse the chemo brush with hydrogen peroxide and water, or with a diluted bleach solution after each use, and change chemo brushes weekly. The brush may also be cleaned in a dishwasher. Saliva production is greatly reduced as a consequence of radiation. The resulting xerostomia causes the inability to eat dry foods and may be permanent. Teach the patient regarding the use of saliva substitutes. Skin reactions are also a common side effect of radiation. Instruct the patient to avoid sun exposure, to avoid perfumed lotions or powders, and to cleanse the face or neck area with a gentle, non-deodorant soap. Teach male patients to use an electric razor for shaving and to avoid alcohol-based aftershave lotions to prevent further skin irritation. Healthcare resources. Patients who have undergone composite resection often require community services because they have both physical and psychosocial needs. Depression related to a change in body image is common. Excision of a portion of the jaw can leave a facial defect that may be difficult to hide. A social worker or other health care professional may be needed for patient and family counseling. Those who have undergone a total glossectomy may be able to speak with special training and the use of an intraoral prosthesis created by a maxillofacial prosthodontist. The prosthesis is similar to dentures. A case manager provides assistance in obtaining special equipment or nutritional resources required by the patient at home. He or she assesses the patient's financial needs and makes referrals to government, community, and religious organizations as needed. Refer the patient to the American Cancer Society, ACS, www.cancer.org, or the Oral Cancer Foundation, www.oralcancerfoundation.org, for local support groups and resources, including additional information. The ACS often supplies dressing supplies and transportation to and from follow-up visits or medical treatments. Decision-making challenge. Coordination of care. You are assigned to visit a middle-aged adult who recently had a partial glossectomy to remove a cancerous tumor. He was formerly a professional baseball player who used chewing tobacco for many years. The patient is receiving parenteral nutrition, and he reports being hungry all the time. He is on Humulin R insulin for his diabetes, which has been uncontrolled since he had his surgery. The patient is very angry and depressed and states to his wife that he can't live like this. She is concerned that he will try to commit suicide unless his health improves. 1. How should you respond to the patient's wife at this time? 2. What other healthcare professionals need to be included in managing this patient? 3. How will you coordinate his care with members of the healthcare team? And 4. What other priorities for care do you have for the patient during this home visit? And that was oral cancers. Okay, on to laryngeal, described in Iggy as head and neck. Page 597 to 606. Head and neck cancer, pathophysiology. Head and neck cancer can disrupt breathing, eating, facial appearance, self-image, speech, and communication. This form of cancer can be devastating even when treated successfully. The care needs for patients with these problems are complex, requiring a coordinated and comprehensive team approach. The patient can receive appropriate care only after the location and size of the tumor are accurately identified. Head and neck cancer is curable when treated early. The prognosis for those who have more advanced disease at diagnosis depends on the extent and location of the tumor. Untreated cancer of the head and neck is a fatal disease within 2 years of diagnosis. Most head and neck cancers, 80%, are squamous cell carcinomas of the mucosa that are slow-growing, taking several years to develop. Often these tumors first appear as deep ulcerations. The cancer begins when the mucosa is chronically irritated and changes into a tougher mucosa, squamous metaplasia. This tougher mucosa occurs by increasing the mucosal thickness, or the acanthosis or hyperplasia, or by developing a keratin layer, or keratosis. At the same time, genes controlling cell growth are damaged, allowing growth enhancement of these abnormal cells, which eventually become malignant. These lesions may then take the form of white patchy lesions, or leukoplakia, or red velvety patches, erythroplasia. The growth and spread of metastasis of head and neck cancer first occurred into nearby structures such as lymph nodes, muscle, and bone. Systemic spread through the blood and lymphatic systems to distant sites may also occur, usually to the lungs or liver. The degree of malignancy is determined by cellular analysis. Early-stage cancers are described as carcinoma in situ and well differentiated. Without treatment, cancers progress to be moderately differentiated and finally poorly differentiated. Most head and neck cancers arise from mucous membrane and skin, but they also can start from salivary glands and the thyroid or other structures. Treatment is based on tumor cell type and degree of spread at diagnosis. Etiology. Many risk factors contribute to the development of head and neck cancer, but the actual cause is unknown. The two most important risk factors are tobacco and alcohol use, especially in combination. Other risk factors include voice abuse, chronic laryngitis, exposure to industrial chemicals or hardwood dust, and poor oral hygiene. Another problem being explored as a possible cause of head and neck cancer is long-term or severe gastroesophageal reflux disease, or GERD. Incidence/prevalence. The frequency of head and neck carcinoma is increasing. The American Cancer Society, ACS, estimates 45,000 newly diagnosed cases of oral and laryngeal cancers occur in the United States each year. This cancer type accounts for more than 4% of all carcinomas and more than 11,000 deaths per year. Men are affected 3 times more often than women. Most head and neck cancers occur in people older than 60 years. Patient-centered collaborative care assessment history. The patient with head and neck cancer may have difficulty speaking because of hoarseness, shortness of breath, tumor bulk, and pain. It is important to be sensitive to these difficulties during the interview. Ask about tobacco and alcohol use, history of recurrent, acute, or chronic laryngitis or pharyngitis, oral sores, and lumps in the neck. Calculate the patient's smoking history by the number of packs smoked per day times the number of years the patient has smoked, pack-years. Ask about alcohol intake, how many drinks per day, and for how many years. These questions may be uncomfortable for both you and the patient, but are an important part of the history. Also ask about exposure to environmental or occupational pollutants. Assess problems related to risk factors. For example, nutrition may be poor because of alcohol intake and impaired liver function. Assess dietary habits and any weight loss. Ask about any chronic lung disease which may have an impact on the patient's breathing pattern. Physical assessment, clinical manifestations, Table 31.1. Table 31.1 lists the warning signs of head and neck cancers. With laryngeal cancer, painless hoarseness may occur because of tumor size and an inability for the vocal cords to come together for normal speech, called phonation. Lesions of the vocal cords are the earliest form of laryngeal cancer. Any person who has a history of hoarseness, mouth sores, or a lump in the neck for 3 to 4 weeks should be evaluated for laryngeal cancer. Inspection and palpation of the head and neck are important parts of the physical examination. An advanced practice nurse or physician may perform a laryngeal examination using a laryngeal mirror or fiber optic laryngoscope. Lesions may be seen on inspection. The neck is palpated to assess for enlarged lymph nodes. Table 31.1. Warning signs of head and neck cancers. Pain, lump in the mouth, throat, or neck, difficulty swallowing, color changes in the mouth or tongue to red, white, gray, dark brown, or black. Oral lesions or sore that does not heal in 2 weeks, persistent or unexplained oral bleeding, numbness of the mouth, lips, or face, change in the fit of dentures, burning sensation when drinking citrus juices or hot liquids, persistent unilateral ear pain, hoarseness or change in voice quality, persistent or recurrent sore throat, shortness of breath, anorexia, and weight loss. Psychosocial assessment. Often the patient with head and neck cancer has a long-standing history of cigarette or alcohol use or both. The patient or family may feel denial, guilt, blame, or shame once the diagnosis is suspected. Assess the adequacy of support systems and coping mechanisms. Document social and family support because the patient often needs extensive assistance at home after treatment. Collaborate with a social worker as needed. Assess the level of education or literacy of the patient and family to plan teaching before and after surgery. Document any family history of cancer, as well as the patient's age, gender, occupation, and ability to perform ADLs. Ask the patient whether his or her occupation requires continual oral communication. Job retraining may be needed if treatment affects speech. Laboratory assessment. Diagnostic tests include a complete blood cell count, bleeding times, urinalysis, and blood chemistries. The patient with chronic alcoholism may have low protein and albumin levels from poor nutrition. Renal and liver function tests are performed to rule out cancer spread and to evaluate the patient's ability to metabolize drugs and chemotherapy agents. Imaging assessment. Many types of imaging studies, including X-rays of the skull, sinuses, neck, and chest, are useful in diagnosing cancer spread, other tumors, and the extent of tumor invasion. CT of the head and neck, with or without contrast media, helps evaluate the tumor's exact location. MRI can help differentiate normal from diseased tissue, and MRI is more sensitive than a CT in defining the extent of soft tissue invasion. The brain, bone, and liver are evaluated with nuclear imaging, bone scans, single photon emission, computerized tomography or SPECT scans, and PET scans. These tests help locate additional tumor sites. Other diagnostic assessment. Other helpful tests include direct and indirect laryngoscopy, tumor mapping, and biopsy. Panendoscopy, laryngoscopy, nasopharyngoscopy, esophagoscopy, and bronchoscopy is performed with general anesthesia to define the extent of the tumor. Tumor mapping biopsies are performed to identify tumor location. Biopsy tissues taken at the time of the panendoscopy confirm the diagnosis and determine the tumor type, cell features, and location. Tumor staging by the TNM or tumor node metastasis method, see Chapter 23, is also performed. Analysis. Common nursing diagnosis and collaborative problems. The primary collaborative problem is potential for respiratory obstruction. Priority nursing diagnosis for patients with head and neck carcinomas are 1. Risk for aspiration related to edema, anatomic changes, or altered protective reflexes. 2. Anxiety related to threat of death, change in role status, or change in economic status. 3. Disturbed body image related to tumor and treatment modalities. Additional nursing diagnoses and collaborative problems. In addition to the common nursing diagnosis and collaborative problems, patients with head and neck carcinomas may have one or more of these: acute pain or chronic pain related to tumor invasion of tissues and nerves and surgical intervention, imbalanced nutrition, less than body requirements related to dysphagia, anxiety, tumor process, surgical resection, or chronic alcohol intake, impaired verbal communication related to tumor invasion, hoarseness, pain, or surgical resection, impaired skin integrity related to altered circulation, nutritional deficit, tumor invasion, radiation, chemical factors, body secretions or substances, or surgical wound, ineffective coping related to altered body image, communication method, or ineffective social support, impaired social interaction related to body image discernments and lifestyle practices, deficient knowledge, treatment regimen, and resources related to lack of exposure to or lack of interest in learning. Planning and implementation. Potential for respiratory obstruction. Planning expected outcomes. The patient with head and neck cancer is expected to attain and maintain adequate tissue oxygenation. Indicators include arterial blood gas values within the normal range, rate and depth of respiration within the normal range, pulse ox within the normal range, absence of cyanosis, osis, or pallor. Interventions. The goal of treatment is to remove or eradicate the cancer while preserving as much normal function as possible. The physician presents the available treatment options. Surgery, radiation, or chemotherapy may be used alone or in combination. In planning treatment options, the patient's general physical condition, nutritional status, and age, the effects of the tumor on body function, and the patient's personal choice are all considered. Treatment for laryngeal cancer may range from radiation therapy for a small specific area or tumor to total laryngopharyngectomy with bilateral neck dissections followed by radiation therapy. The specific treatment depends on the extent and location of the lesion. Voice conservation procedures are used only if they do not risk incomplete removal of the tumor. Nursing care focuses on the patient's total needs, including preoperative preparation, competent in-hospital care, discharge planning and teaching, and extensive outpatient rehabilitation. Non-surgical management. Monitor the respiratory system by assessing respiratory rate, breath sounds, pulse, oximetry, arterial blood gas values, and the results of pulmonary function tests. Respiratory distress may indicate narrowing of the airway related to tumor growth, edema, or both. Position the patient for optimal air exchange. Teach the patient family about the use of Fowler's and semi-Fowler's position. Sitting upright in a reclining chair may promote more comfortable breathing. Chapter 5 and 9 provide additional information on palliation and pain control for patients who elect not to have therapy and for those whose therapy has not been effective. Radiation therapy for treatment of small cancers in specific locations has a cure rate of at least 80%. The cure rate for large cancers is lower when radiation is used as the only therapy. Standard therapy uses 5,000 to 7,000 rad or radiation absorbed dose, usually over 6 weeks and in daily or twice daily doses. Radiation may be used alone or in combination with surgery. Because radiation therapy slows tissue healing, it might not be performed before surgery. Radiation therapy is an outpatient treatment. See Chapter 24. Most patients have hoarseness, dysphagia, skin problems, and dry mouth for a few weeks after radiation therapy. Hoarseness may become worse. Reassure the patient and family that voice improves within 4 to 6 weeks after completion of radiation therapy. Urge the patient to use voice, rest, and alternate means of communication until the effects of radiation therapy have passed. Most patients have a sore throat and difficulty swallowing during radiation therapy to the neck. Gargling with saline or sucking ice may decrease discomfort. Mouthwashes and throat sprays containing a local anesthetic agent such as lidocaine or diphenhydramine can provide temporary relief. Analgesic drugs may be prescribed. The skin at the site of the irradiation becomes red and tender and may peel during therapy. Instruct the patient to avoid exposing this area to sun, heat, cold, and abrasive treatments, such as shaving. Teach the patient to wear protective clothing made of soft cotton and to wash this area gently with a mild soap such as Dove. Stress that only the lotions or powders prescribed by the radiation oncologist should be used on the skin until the area has healed. If the salivary glands are in the path of irradiation, the patient has a dry mouth or xerostomia. This side effect is long-term and may be permanent. Some of the problems from reduced saliva include increased risk for dental caries, increased risk for oral infections, halitosis or bad breath, and taste changes. Although there is no cure for xerostomia, interventions can help reduce the discomfort. Heavy fluid intake, particularly water and humidification, can help ease the discomfort. Some patients benefit from the use of artificial saliva, such as Salivart, or saliva stimulants, such as Saligen or Cevimeline, are cholinergic drugs. Chewing gum and sucking hard candy may relieve dry mouth temporarily. Chemotherapy can be used alone or in addition to surgery or radiation for head and neck cancers. Chapter 24 discusses the general care needs of patients receiving chemotherapy. Okay, surgical management, tumor size and location, TNM classification. Determines the type of surgery needed for the specific head and neck cancer. Very small, early stage tumors may be removed by laser therapy or photodynamic therapy. However, few head and neck tumors are found at this stage, and most require extensive traditional surgery. Reconstruction is also determined by the tumor size and amount of tissue to be resected and reconstructed. Surgical procedures for head and neck cancers include laryngectomy, total and partial, tracheostomy, and oropharyngeal cancers resections. The major types of surgery for laryngeal cancer include cord stripping, removal of vocal cord, cordectomy, partial laryngectomy, and total laryngectomy. If cancer is in the lymph nodes in the neck, or if the tumor has a high rate of nodal spread, the surgeon performs a nodal neck dissection along with the removal of the primary tumor, or radical neck. A pathologist evaluates the resected lymph nodes for tumor invasion. Preoperative care. Teach the patient family about the tumor. The surgeon explains the surgical procedure and obtains informed consent. Discuss and interpret the implications of such consent with the patient and family. Explain about self-care of the airway, alternate methods of communication, suctioning, pain control methods, the critical care environment, including ventilators and critical care routines, nutritional support, feeding tubes, and goals for discharge. The patient will need to learn new methods of speech, help him or her prepare for this change before surgery to practice the use of an alternate form of communication, e.g. pen and pencil, magic slate, picture alphabet board, or a computerized word generator. Determine the communication method most preferred by the patient. A team approach for planning care and rehabilitation is critical for the best outcome. The team includes nurses, physicians, speech-language pathologists, social workers, nutritionists, respiratory therapists, and occupational and physical therapists. Professionals from all these disciplines help evaluate and prepare the patient for who has had head and neck cancers. Chapter 16 describes general preoperative assessment and education. Operative procedures. Table 31.2 lists specific information about the various surgical procedures for laryngeal cancer. Hemilaryngectomy, vertical or horizontal, and supraglottic laryngectomy are types of partial voice conservation laryngectomies. To protect the airway, a tracheostomy is needed. With a partial laryngectomy, the tracheostomy is usually temporary. With a total laryngectomy, the upper airway is separated from the throat and esophagus, and the trachea is brought out through the skin in the neck and sutured in place, creating a stoma. This airway opening, a laryngectomy stoma, is permanent. Neck dissection includes the removal of lymph nodes, the sternocleidomastoid muscle, the jugular vein, the 11th cranial nerve, and surrounding soft tissue. Because the 11th cranial nerve, spinal accessory nerve, is cut during the procedure, shoulder drop will be present after surgery. Physical therapy exercises are needed after surgery to help the patient ease the shoulder drop by using other muscle groups. Postoperative care. Head and neck surgery often lasts 8 hours or longer. Usually the patient spends the immediate period after surgery in the surgical intensive care unit. Monitor airway patency, vital signs, hemodynamic status, and comfort level. Monitor hemorrhage and other general complications of anesthesia and surgery. Take vital signs hourly for the first 24 hours and then every 2 hours or according to agency policy until the patient is stable. After the patient is transferred from the critical care unit, monitor vital signs every 4 hours or according to agency policy. The patient is generally out of bed by the second day. Complications after surgery include airway obstruction, hemorrhage, wound breakdown, and tumor recurrence. The first priorities after head and neck surgery are airway maintenance and ventilation. Other priorities are wound, flap, and reconstructive tissue care, pain management, nutrition, and psychological adjustment, including speech and language therapy. Airway maintenance and ventilation. Immediately after surgery, the patient may need ventilatory assistance because of a long-term smoking history, chronic lung disease, and a long duration of anesthesia. Most patients wean easily from the ventilator after this type of surgery because the thoracic and abdominal cavities are not entered. During weaning, the patient usually uses a tracheostomy collar over the official airway or open stoma with oxygen and humidity to help move mucus secretions. Secretions may remain blood-tinged for 1 to 2 days. Use body substance precautions and report any increase in bleeding to the surgeon. Humidity helps remove crusts and prevent obstruction of the tube with secretions. Some surgeons prescribe installations of 5 to 10 milliliters of sterile saline or sodium bicarbonate into the airway every 2 hours. However, this practice is controversial. Table 31.2, surgical procedures for laryngeal cancer and their effect on voice quality. Procedure, laser surgery. Description, tumor reduced or destroyed by laser beam through laryngoscope, resulting voice quality, normal or hoarse. Transoral chordectomy, tumor or early lesion resected through laryngoscope, and that would be voice quality. Afterwards would be normal or hoarse, high cure rate. Laryngeal fissure, no cord removed, early lesion. That's normal and high cure rate on the voice. Supraglottic partial laryngectomy, hyoid bone, false cords, and epiglottis removed, and you still have a normal hoarse voice resulting. Also, neck dissection on affected side performed if nodes involved. That's for supraglottic. Hemilaryngectomy or vertical laryngectomy. One true cord, one false cord, and one half of thyroid cartilage removed, and that will leave you hoarse. And then total laryngectomy, entire larynx, hyoid bone, strap muscles, 1 or 2 tracheal rings removed. Nodal neck dissection if nodes involved, and there'd be no natural voice left after that. A laryngectomy tube is used for patients who have undergone a total laryngectomy and need an appliance to prevent scar tissue shrinkage of the skin tracheal border. This tube is similar to a tracheostomy tube but is shorter and wider with a larger lumen, figure 31.5. Laryngectomy tube care is similar to tracheostomy tube care, see chapter 30, except that the patient can change the laryngectomy tube daily or as needed. A laryngectomy button is similar to a laryngectomy tube but is softer, has a single lumen, and is very short. A button is comfortable for the patient, is easily removed for cleaning, and is available in various sizes and lengths for a custom fit. Provide a magic slate or paper or pencil for communication because the patient cannot speak other than mouthing words. Coughing, deep breathing, and saline installation are usually effective in clearing secretions. The lack of a surgical incision in the chest or abdomen improves the ability to cough. Instruct the patient how to cough and deep breathe to clear secretions. Oral secretions can be suctioned by the alert patient using a Yankauer or tonsillar suction or a soft red latex catheter. Teach the patient to suction away from the side of the surgery to prevent wound opening immediately after surgery. Patients can participate in their own care by using a table mirror or for visibility. Provide a clean environment for the catheter. Stoma care after a total laryngectomy is a combination of wound care and airway care. Inspect the stoma with a flashlight. Clean the suture line with half-strength hydrogen peroxide to prevent secretions from forming crusts and obstructing the airway. Perform suture line care every 1 to 2 hours during the first few days after surgery and then every 4 hours thereafter. The mucosa of the stoma and trachea should be bright and shiny and without crusts, similar to the appearance of the oral mucosa. Wound, flap, and reconstructive tissue care. Tissue flaps may be used to close the wound and improve appearance. Commonly used reconstructive flaps are myocutaneous flaps, island flaps, rotation flaps, trapezius flaps, and split-thickness skin grafts. Figure 31.5 shows a laryngectomy tube. Note that the outer cannula is shorter and has a diameter wider than that of the tracheostomy tube. Okay, so back to the flaps. Split thickness skin grafts, or STSGs, and free flaps with microvascular anastomosis. Flaps are skin, subcutaneous tissue, and sometimes muscle taken from other body areas. These flaps may be used for reconstruction after any type of head and neck resection. After neck dissection, the surgeon places an STSG over the exposed carotid artery before covering it with skin flaps or reconstructive flaps. The first 24 hours after surgery are critical. Evaluate all grafts and flaps hourly for the first 72 hours. Monitor capillary refill, color, drainage, and Doppler activity of the major feeding vessels. Report changes to the surgeon immediately because surgical intervention may be needed. Position the patient so that the side of the head and neck with the flaps is not dependent. Hemorrhage. Hemorrhage is a possible complication after any surgery, but is uncommon with laryngectomy. The surgeon often places a closed surgical drain in the neck area to collect blood and drainage for about 72 hours after surgery. The drain also helps maintain the position of the reconstructed skin flaps. Any drain obstruction or equipment malfunction may cause a buildup of blood or serum under the flaps. This collection can impair blood flow to and from the flaps, resulting in flap failure and tissue loss. A sudden stoppage of drainage may indicate a clot obstructing the drain. Monitor drainage and record its amount and character. Check the patency and functioning of the drainage system. Report any drain malfunction or change in flap appearance to the surgeon. Depending on the surgeon's prescription and the agency's policy, you may need to empty the drainage container or milk the drain. Wound breakdown. Wound breakdown is a common complication caused by poor nutrition, a long smoking history, alcohol use, wound contamination, and previous radiation therapy. Manage wound breakdown with packing and local care as prescribed to keep the wound clean and to stimulate the growth of healthy granulation tissue. Wounds may be extensive and the carotid artery may be exposed. Split thickness skin grafts often are placed over the carotid artery for protection in the event of wound dehiscence. As the wound heals, granulation tissue covers the artery and prevents rupture. If granulation is slow and the carotid artery is at risk, another surgical flap may be made to cover the carotid artery and close the wound. When the carotid artery ruptures, large amounts of bright red blood spurt quickly. It is also possible for the carotid artery to have a small leak with continuous oozing of bright red blood. Usually a small leak leads to a complete rupture within a short time. If a carotid artery leak is suspected, call the rapid response team and do not touch the area because additional pressure could cause an immediate rupture. If the carotid artery ruptures because of drying or infection, immediately place constant pressure over the site and secure the airway. Maintain direct manual continuous pressure on the carotid artery and immediately transport the patient to the operating room for carotid resection. Do not leave the patient. Carotid artery rupture has a high risk of stroke and death. Nursing response can save the patient's life. Pain management. Pain is caused by the surgical cutting or manipulation of tissue and by nerve compression. Pain should be controlled, and the patient should still be able to participate in his or her care. Morphine often is given IV by a patient-controlled analgesia or PCA pump for the first 1 to 2 days after surgery. As the patient progresses, liquid opioid analgesics can be given by feeding tube. Oral drugs for pain and discomfort are started only after the patient can tolerate oral intake. After discharge, the patient still requires pain management, especially if he or she is receiving radiation therapy. An adjunct to pain regimen may be liquid NSAIDs. These drugs provide excellent pain relief and can be used along with opioid analgesics. Amitriptyline or Elavil or other tricyclic antidepressants may also be used for the lancinating pain of nerve root involvement. Ouch. Nutrition. A nasogastric gastrostomy or jejunostomy tube is placed during surgery for nutritional support while the head and neck heal. Initially, the patient receives IV fluids or parenteral nutrition until the intestinal tract has recovered from the effects of anesthesia. After that, nutrients can be given via the feeding tube. The nutritional support team or nutritionists assess the patient before surgery and is available for consultation after surgery. The common nutrition goal is to provide 35 to 45 kcals per kilogram of body weight daily. Replacement of protein and water loss is calculated carefully. The nasogastric tube, the most commonly used type of tube, usually remains in place for 7 to 10 days after surgery. Before removing the tube, assess the patient's ability to swallow if nutrition is to be given by mouth. Aspiration cannot occur after a total laryngectomy because the airway and esophagus have been completely separated. Reassure the patient that aspiration will not occur and stay with him or her during the first few swallowing attempts. Swallowing may be uncomfortable at first and analgesics may be needed. Speech and language rehabilitation. The patient's voice quality and speech are altered after surgery. Although this problem has enormous effects on the patient's ability to maintain social interactions, continue employment, and maintain a desired quality of life, it is often poorly addressed while he or she is hospitalized. Working with him or her and the family toward developing an acceptable communication method during the inpatient period is essential for satisfactory outcome. Together with the speech and language pathologist, SLP, discuss the principles of speech therapy with the patient and family early in the course of the treatment plan. See Chart 31.2. Voice and speech differences depend on the type of surgical resection. See Table 31.2. Speech production varies with patient practice, amount of tissue removed, and radiation effects, but the speech can be very understandable. The speech rehabilitation plan for patients who have a total laryngectomy at first consists of writing, using a picture board, or using a computer. The patient then uses an artificial larynx and ideally eventually learns esophageal speech. For success, that's weird. For success, the patient needs encouragement and support from the speech pathologist, hospital team, and family while relearning to speak. This process can be time-consuming and requires concentration each time the patient speaks. Having a laryngectomy, a person who has had a laryngectomy, laryngectomy, it's the same word, but anyways, someone who's had a laryngectomy, from one of the local self-help organizations, visit the patient and family is often beneficial. The International Association of Laryngectomies is very active and supportive, as is the American Cancer Society Visitor Program. Common means of speech communication after laryngectomy include esophageal speech, the use of mechanical devices, and the use of tracheoesophageal fistula, or TEF. Esophageal speech is attempted by most patients who have a total laryngectomy. Sound can be produced this way by burping the air swallowed or injected into the esophageal pharynx and shaping the words in the mouth. Ooh. The voice produced is a monotone. It cannot be raised or lowered and carries no pitch. In the English language, the vocal cords are required for 15 consonants. The remaining 10 consonants can be formed by shaping the mouth. If patients do not have adequate hearing, esophageal speech will be difficult because they need to use their mouth to shape the words as they hear them. Hearing impaired patients may need hearing aids. Some patients have intestinal bloating as a result of swallowing air for esophageal speech. Antacids may help reduce bloating sensations. Esophageal speech also helps strengthen the respiratory and abdominal muscles, which aids in clearing secretions and in breathing. Mechanical devices called electrolarynges may be used by the patient who cannot attain esophageal speech. Most are battery-powered devices placed against the side of the neck or cheek. The air inside the mouth and throat is vibrated, and the patient moves his or her lips and tongue as usual. Another external device, Cooper Rand, also battery-powered, consists of a plastic tube that is placed in the patient's mouth and vibrates during speech. The quality of speech generated with these devices is robot-like and does not sound natural. Tracheoesophageal fistulas, or TEFs, may be used if esophageal speech is ineffective and if the patient meets strict criteria. A surgical connection, or fistula, is created between the trachea and the esophagus using a special catheter. The fistula can be created either at the time of the laryngectomy or later. After the fistula heals, a silicone prosthesis, e.g. the Blom-Singer prosthesis, is inserted in place of the catheter. The patient covers the stoma and the opening of the prosthesis with a finger, or opens and closes the opening with a special valve to divert air from the lungs through the trachea into the esophagus and out of the mouth. Lip and tongue movement, not the prosthesis itself, produces speech. Surgical procedures for other head and neck cancers. The major types of surgeries for other head and neck cancers are called composite resections. These resections are a combination of surgical procedures including partial or total glossectomies, partial mandibulectomies, and, if needed, nodal neck dissections. Tracheostomy may be planned to provide an adequate airway. See Chapter 56 for more information about oral cancer. Tracheotomy. A tracheotomy is a surgical incision into the trachea for the purpose of establishing an airway. Tracheostomy. It can be performed as an emergency procedure or as a scheduled surgical procedure. A tracheostomy can be temporary or permanent. Chapter 30 discusses the nursing care of a patient with a tracheostomy. Decision-making challenge. Critical rescue. The patient is a 70-year-old man who is 5 days post-op after a laryngectomy and radical neck dissection for a laryngeal cancer. When you change the dressing, you observe the graft over the carotid artery appears dry and dusky. On closer inspection, you notice that the whole graft is pulsating very strong and some bright red blood is seeping around the edge of the graft. Oh no! What type of complication is most likely occurring? Should you continue with wound care? Why or why not? Should you call the rapid response team or the surgeon? Why or why not? Should you apply pressure to the graft? Why or why not? Yes, the carotid artery is leaking or seeping or burst, and call the rapid response team. Don't continue any wound care. Okay, figure 31.6, examples of tracheoesophageal prosthesis. And that shows a Blom-Singer trapdoor prosthesis and the Ponge voice button. Risk for aspiration, planning, expected outcomes. The patient with head and neck cancer is expected not to aspirate food, gastric contents, or oral secretions into the lungs. Indicators include that the patient often or consistently demonstrates these behaviors: positions self upright for eating or drinking, selects foods according to swallowing ability, chooses liquids and foods of proper consistency. Interventions. The surgical changes in the upper respiratory tract and altered swallowing mechanisms increase the patient's risk for aspiration. Aspiration can result in life-threatening pneumonia, weight loss, prolonged hospitalization, and increased costs. Chart 31.3 lists actions for aspiration prevention. The presence of a nasogastric or NG feeding tube may further increase the potential for aspiration because it keeps the lower esophageal sphincter partially open. The one exception is the patient who has undergone a total laryngectomy. In these cases, the airway is separated from the esophagus, making aspiration impossible. Such a patient is not at risk. A dynamic swallow study, such as a barium swallow under fluoroscopy, evaluates the patient's ability to protect the airway from aspiration and helps determine the appropriate method of swallow rehabilitation. In many cases, enteral feedings are used either because of the patient's inability to swallow or because of continued aspiration risk. When an NG tube is in place, help prevent aspiration with the use of routine reflux precautions. These precautions include elevating the head of the bed and strictly adhering to tube feeding regimens, including no bolus feedings at night. Check residual feeding before each bolus feeding or every 4 to 6 hours with continuous feeding, and evaluate the patient's tolerance of the tube feeding. If the residual volume is high, above 100 mL for bolus feeding or 2 hours worth of continuous tube feeding, or as otherwise prescribed by the physician, withhold the feeding and notify the physician. Check the pH of pulmonary secretions because residual volume cannot be checked with narrow feeding tubes. Use other techniques to assess tube placement. See Chapter 6.3 for interventions related to NG tubes and tube feedings. Chart 31.3, best practice for patient safety and quality care. Prevention of aspiration during swallowing. Avoid having meals when the patient is fatigued. Provide smaller and more frequent meals. Provide adequate time. Do not hurry the patient. Provide close supervision if the patient is self-feeding. Keep emergency suctioning equipment close at hand. Avoid water and other thicken liquids. Avoid foods that generate thin liquids during the chewing process, such as fruit. Position the patient in the most upright position possible. When possible, completely or at least partially deflate the tube cuff during meals. Suction after initial cuff deflation to clear the airway and allow maximum comfort during the meal. Feed each bite or encourage the patient to take each bite slowly. Encourage the patient to dry swallow after each bite to clear residual from the throat. Avoid consecutive swallows by cup or straw. Provide controlled small volumes of liquids using a spoon. Encourage the patient to tuck his or her chin down and move the forehead forward while swallowing. Allow the patient to indicate when he or she is ready for the next bite. If the patient coughs, stop the feeding until the patient indicates the airway has been cleared. Continuously monitor tolerance to oral food intake by assessing respiratory rate, ease, pulse ox, and heart rate. Swallowing can be a major problem for the patient who has a tracheostomy tube. Swallowing can be normal if the cranial nerves and anatomic structures are intact. In a normal swallow, the larynx rises and moves forward to protect itself from the passing stream of food and saliva. Laryngeal rising also helps open the upper esophageal sphincter. The tracheostomy tube sometimes fixes the larynx in place, making it unable to perform this motion efficiently. The result is difficulty in swallowing. An inflated tracheostomy tube cuff can balloon backward into the esophagus and interfere with the passage of food. The common wall of the posterior trachea and the anterior esophagus is very thin, which allows this pushing action. The patient with head and neck cancer who is cognitively intact may adapt to eating normal food when the tracheostomy tube is small and the cuff is not inflated. The patient who has had a partial vertical or supraglottic laryngectomy must be observed for aspiration. It is critical to teach the patient to use alternate methods of swallowing using aspiration. The supraglottic method of swallowing is especially effective after a partial laryngectomy or base of tongue resection. To reinforce teaching and learning, place a chart in the patient's room detailing the steps. A dynamic swallow study is performed to guide rehabilitation for swallowing and to evaluate the patient's ability to protect the airway. Anxiety. Planning. Expected outcomes. The patient with head and neck cancer is expected to have decreased anxiety. Indicators include that the patient often or consistently demonstrates verbalization of reduced anxiety, absence of distress, irritability, and facial tension, effective use of coping strategies. Interventions. Conferences with a physician, clinical nurse specialists, nutritionist, speech and language pathologist, physical therapist, psychologist, social worker, and general nursing staff may be beneficial. Explore the reason for anxiety, e.g., fear of the unknown, lack of teaching, fear of pain, fear of airway compromise, fear of hospitalization, loss of control. The patient and family often benefit from further information before the patient is scheduled for surgery and while still at home. Home care nurses or community-sponsored programs such as ACS may be able to decrease fears about the disease process and surgical interventions.
Bye. I'm going wireless.
Chart 31.4, Patient and Family Education Guide. The supraglottic method of swallowing. 1. Place yourself in an upright, preferably out-of-bed position. 2. Clear your throat. 3. Take a deep breath. 4. Place half to 1 teaspoon of food into your mouth. 5. Hold your breath or bear down, Valsalva's maneuver. 6. Swallow twice. 7. Release your breath and clear your throat. 8. Swallow twice again. 9. Breathe normally. This method exaggerates the normal protective mechanisms of cessation of respiration during the swallow. The double swallow attempts to clear food that may be pooling in the pharynx, vallecula, and piriform sinuses. This method is used only after a dynamic radiographic swallow study has demonstrated that it is appropriate and safe for the patient. Give prescribed anti-anxiety drugs such as diazepam, Valium, Meval, with caution because of the possibility of respiratory depression and because some of these drugs are eliminated slowly. Shorter duration drugs such as lorazepam, Ativan may have fewer respiratory side effects. The location of the tumor and the presence of any other lung disease may cause some degree of airway obstruction. For anxiety in these patients, the physician prescribes drug therapy judiciously and may choose lorazepam or Ativan nor lorazepam rather than sedating agent. Disturbed body image. Planning. Expected outcomes. The patient with head and neck cancer is expected to accept body image changes. Indicators include that the patient often or consistently demonstrates willingness to touch the affected body part, willingness to use strategies to enhance appearance, participation in self-care, interaction with visitors, staff, and family members. Interventions. The patient with head and neck cancer may have a permanent change in body image because of deformity, the presence of a stoma or artificial airway, speech changes, and a change in the method of eating. He or she may not be able to speak at all or have permanent hoarseness or speech deficits. Help him or her set realistic goals, starting with involvement in self-care. Teach the patient alternate communication methods so he or she can functionally communicate in the hospital and after discharge. Teach the family to ease the patient into a normal social environment. Use positive reinforcement and encouragement while demonstrating acceptance and caring behaviors. The family also may benefit from counseling sessions while the patient is still in the hospital. After surgery, the patient may feel socially isolated because of the change in voice and facial appearance. Loose-fitting, high-collar shirts or sweaters, scarves, and jewelry can be worn to cover the laryngectomy stoma, tracheostomy tube, and other changes related to surgery. Cosmetics may aid in covering disfigurement. Most surgeons try to place the incisions in the natural skin fold lines if doing so does not pose a risk for cancer recurrence. Community-based care. If no complications occur, the patient is usually discharged home or to an extended care facility within 2 weeks. At the time of discharge, he or she or a family member should be able to perform tracheostomy or stoma care and participate in nutrition, wound care, and communication methods. The patient and family may feel more secure about discharge if they receive a referral to select support groups or a community health agency familiar with the care of patients recovering from head and neck cancer. The nurse coordinates the efforts of the healthcare team in assessing the specific discharge needs and making the appropriate referrals to home care agencies. Professionals such as nutritionists, nurses, physical therapists, speech and language pathologists, and social workers may be needed. Coordinate the scheduling for chemotherapy or radiation therapy with the patient and family. Home care management. Extensive home care preparation is needed after laryngectomy for cancer. The convalescent period is long and airway management is complicated. The patient or family must be able to take an active role in care. General cleanliness of the home is assessed by the home care nurse or case manager. For the patient with severe respiratory problems, home changes to allow for one-floor living may be needed. Increased humidity is needed. A humidifier add-on to a forced air furnace can be obtained. If this cost is not manageable or if the home is heated by radiators, a room humidifier or vaporizer may be used. Be sure to stress that meticulous cleaning of these items is needed to prevent spread of mold or other sources of infection. A home care nurse often is involved with care after discharge and is an important resource for the patient and family. This nurse assesses the patient and home situation for problems in self-care, complications, adjustment, and adherence to the medical regimen. Chart 31.5 lists assessment areas for the patient in the home after a laryngectomy. This nurse reinforces healthcare teaching, self-care teaching, and smoke cessation regimens. Health teaching. Education begins before surgery, and most self-care is taught in the hospital. Teach the patient and family how to care for the stoma or tracheostomy or laryngectomy tube, depending on the type of surgery performed. Review incision and airway care, including cleaning and inspecting for signs of infection. Chart 31.6 lists self-care actions for the patient after laryngeal cancer surgery. Many of these actions also apply to any surgery for head and neck cancer. Chart 31.5 home care assessment, patients after laryngectomy. Assess respiratory status, observe rate and depth of respiration, auscultate lungs, check patency of airway, examine the tracheostomy drainage for amount, color, and character, examine nail beds and mucous membranes for evidence of cyanosis, obtain a pulse oximetry reading, assess condition of wound, remove dressings, noting condition of dressings, cleanse the wound, compare with previous notations of wound condition, presence, amount, and nature of exudate, presence, absence of cellulitis, presence, absence of odor. Assess patient's psychosocial status. Ask the patient about passing the time, visitors, and trips outside the house. Observe whether the patient communicates responses directly or whether a family member speaks for the patient. Observe patient and family member interactions. Determine what method of communication the patient has selected and observe the patient's skill with it. Observe whether the patient is wearing pajamas or is dressed in street clothes. Take the patient's temperature at each home visit. Assess the patient's understanding of illness and adherence to treatment. Manifestations to report to the healthcare provider. Medication plan, correct timing and dose, ambulation or positioning schedule, dressing changes, skin care, diet modification, 24-hour diet recall, skill in tracheostomy or dressing care. Assess patient's nutritional status, change in muscle mass, lackluster nails, sparse hair, recent weight loss greater than 10% of usual weight, impaired oral intake, difficulty swallowing, generalized edema. Back to the text. Stoma care. Teaching is focused on protection. Instruct the patient to use a shower shield over the tube or stoma when bathing to prevent water from entering the airway. Teach men who use electric shavers to cover the stoma while shaving to keep hair from falling into it. Suggest that the patient wear a protective cover or stoma guard to protect the stoma during the day. For those with permanent stomas, after laryngectomy, for those with permanent tracheostomies, covering the opening has a double benefit. 1. Filtering the air entering the stoma while keeping humidity in the airway, and 2. Enhancing aesthetic appearance. Attractive coverings are available in the form of cotton scarves, crocheted bibs, and jewelry. Using colored seam binding for tracheostomy ties after the stoma has matured may enhance overall body image. Shirt or dress color can be matched or coordinated with seam bindings of various colors. Okay. Instruct the patient how to increase humidity in the home. If prescribed, teach the patient to instill normal saline into the artificial airway 10 to 15 times a day. Stress the importance of keeping well hydrated to prevent secretions from thickening. Okay. Chart 31.6, Patient and Family Education Guide, Home Laryngectomy Care. Avoid swimming and use care when showering or shaving. Lean slightly forward and cover the stoma when coughing or sneezing. Wear a stoma guard or loose clothing to cover the stoma. Clean the stoma with mild soap and water. Lubricate the stoma with a non-oil-based ointment as needed. Increase humidity by using saline in the stoma as instructed. Bedside humidifier, pans of water, and houseplants. Obtain and wear a medic alert bracelet and emergency care card for life-threatening situations. Back to the text. Communication involves having the patient continue the selected method of alternate communication that began in the hospital. Instruct him or her to wear a medical alert, a bracelet, and carry a special identification card, figure 31.7. For patients with a laryngectomy, this card is available from the local chapters of the International Association of Laryngectomies. The card instructs the reader about providing an emergency airway or resuscitating someone who has a stoma. Smoking cessation is a difficult but important issue after head and neck cancer surgery because smoking is a major risk factor for this type of cancer. Stress that smoking cessation can reduce the risk for developing other cancers and can increase the rate of healing from surgery. Smoking cessation is not an easy task, and most patients need continuing support and reinforcement to sustain this action. Chemical and psychological assistance are available for smoking cessation. See Chapter 38 for a detailed discussion of smoking cessation methods. Psychosocial preparation. The many changes resulting from a laryngectomy influence physical, social, and emotional functioning. Patients may perceive changes in their quality of life. Begin preparing the patient and family by scheduling a visit from a person who has adjusted to these changes. The patient who is discharged to home with a permanent stoma, a tracheostomy tube, NG tube, and wounds has an altered body image. Stress the importance of returning to as normal a lifestyle as possible. Most patients can resume many of their usual activities within 4 to 6 weeks after surgery. Figure 31.7, Emergency Wallet Card for Identification of Laryngectomy. Okay, a longer time is needed after a combination of radiation therapy and surgery, and for those patients who also have chronic disease such as diabetes, mellitus, heart failure, or chronic obstructive pulmonary disease. The patient may be frustrated at times while trying to adjust to changes in appearance, smell, taste, and communication. The patient with a total laryngectomy cannot produce sounds during laughing and crying. Mucus secretions may appear unexpectedly when these emotions arise or when coughing or sneezing occurs. The mucus may be embarrassing, and the patient needs to be prepared to cover the stoma with a handkerchief or gauze. The patient who has undergone composite resections has difficulty with speech and swallowing. He or she may need to deal with tracheostomy and feeding tubes in public places. Healthcare resources. Inform the patient and family of community organizations, e.g. the ACS, and local laryngectomy clubs, which can offer support, information, and friendships. When the patient has problems paying for healthcare services, equipment, and prescriptions, a visiting nurse agency may be helpful in locating available resources. In many areas, the local unit of the ACS or Canadian Cancer Society can help provide dressing materials and nutritional supplements to patients in need. These organizations may also provide transportation to and from follow-up visits or radiation therapy. Decision-making challenge. Coordination of care. A patient who had a laryngectomy and radical neck dissection for laryngeal cancer comes back to the clinic 3 weeks after discharge. She lives with her daughter and grandchild. She tells you that esophageal speech is going well and that her grandsons help her work on burping the words out. She also says she had many visitors and is glad that so many friends are helping her recover. You think she looks thin, and when you weigh her, she weighs 16 pounds less than the day she was discharged from the acute care setting. When you ask her what she is eating, she is a little reluctant but finally tells you she has not been eating much because swallowing is uncomfortable and she is afraid she may choke. 1. Is this weight loss a concern? 2. Are her fears reasonable? Why or why not? 3. What suggestions can you make for improving her nutrition? And 4. Could you coordinate her care to meet her needs? Yeah. Evaluation outcomes. Evaluate the care of the patient with head and neck cancers on the basis of identified nursing diagnosis and collaborative problems. The expected outcomes of that are that the patient maintain a patent airway, performs self-care of the artificial airway and wound, performs ADLs independently or with minimal assistance, attains or maintains adequate nutrition, does not aspirate gastric contents or food, engages in desired social interactions. Specific indicators for these outcomes are listed for each nursing diagnosis and collaborative problem in the planning and implementation section see earlier. And that was laryngeal or head and neck cancer.